Very much, James, for that kind invitation. I was going to chair this session and then a speaker was unable to attend, so now I am giving the talk instead. The last time I was in this room, I was preparing for my daughter's ball. Their school had their ball here, and we had this place looking fantastic with all the decorations and lights and everything. We spent about 4 hours one early morning setting it up. And I was intrigued to see if it was going to be the same venue for this talk today, and I see that it is. So I have mixed emotions about being here, so just forgive me. The ball was quite traumatic because I was involved in organising it. It went off okay, so I didn't lose too many brownie points, and my daughter still speaks to me, so we're all good. This presentation is really a summary of where we think things are going with COPD and some of the changes that have happened or occurred over the last 18 months with respect to some of the clinical trial data and in terms of new medicines becoming available, new inhalers, and also as part of that, some restrictions, if you like, on how those inhalers should be used. And so I've tried to amalgamate what is, I think, relevant to the New Zealand scene, as well as what has been discussed vigorously in various international meetings on this topic. Now, a little bit of variation here. My slides require a little bit of pointing, and I don't have a pointer here that points at my slides. So my co-worker and close colleague of the last 20 years is running the pointer, and this is going to be a very interesting experiment. So just by way of an overview then, just to talk about the treatments that are available, talking about this so-called changing landscape, looking at the new GOLD strategy update, and this is something that you will see in various presentations from respiratory colleagues, respiratory physicians. I'm a general physician, but we see a lot of COPD patients, and this is an evolving series of recommendations based on clinical trial data as it comes to hand. Talk a little bit about where spirometry fits into this story and about the use of these new combination inhalers, the so-called LAMA-LABA, or long-acting muscarinic antagonists, the sort of what was formerly tiotropium, but now has taken on a number of different variations on that, and also the LABA, or long-acting beta agonist. And so these medications are now available to us as part of our regimen for COPD. And what that has done is it has reassessed our views on where we think the use of inhaled corticosteroids now sits. And I must say this is being debated, and I could be giving this talk a year from now and saying something a little bit different. So please forgive me for that. There is also a very big interest on the non-pharmacological treatments for COPD, and this is something that you will all be, I'm sure, aware of and involved in directly, as well as monitoring patients and their ability to use their inhalers. So hopefully we can get through that. So the landscape changed, really, it started changing in March of last year when these inhalers became available. So 6 new inhalers. GSK provided a new version of their ICS LABA medication, combined medication, and then there were 2 LAMAs, or long-acting muscarinic antagonists. So these were glycopyrronium and umeclidinium. They're always easy to say, much harder than tiotropium. But they're basically of a similar type, and they provide a long-acting bronchodilatation. And then there's also these combination inhaler therapies, the so-called LAMA and LABA combination, and I'll talk a little bit about that. Then more recently, that is to say the end of last year, there was the introduction of these new GOLD strategy update, and this provided some small changes from previous years, which I'll try and cover in this presentation. So far we're doing well with the pointer. If we go to the top of this slide, you'll see all the shorter-acting bronchodilators, and these are the inhalers that have been available now for decades in New Zealand, and these are our sort of mainstay of symptom relief, the so-called reliever medications in COPD. And they include the sort of Ventolin-type medications, terbutaline, Atrovent or ipratropium, and also combinations of these. And so these have been around, and we've been able to get away with talking about blue inhalers and green inhalers for quite a while now. And unfortunately, as you can see below this row, there are a lot of other blue and green inhalers now, and life has got a lot more complicated. In the middle, you can see the drugs that are the long-acting beta agonists or the long-acting muscarinic antagonists. Those so-called LAMAs are in the middle row on the right-hand side, and these really provide us with 4 alternates. And then in the bottom row, we have the inhaled corticosteroid LABA combinations on the left, and then the LABA-LAMA on the right in the bottom row. So a lot more to work with, and with that, hopefully, more effective treatment and outcomes for our patient. Now, if I talk a little bit then about what's different about 2017 versus what came before it in terms of this gold strategy. And this is, it's not always an easy story to tell, really, and that is because we have these quadrants, which I'll describe in a minute. The good news is that the basic aims of treatment have not changed, or the goals of treatment are the same: reducing symptoms at the top, relieving symptoms, particularly breathlessness, and improving exercise tolerance, and with that, the improvement in general health and quality of life. The reduction in risk is a little bit more complicated in that we try and reduce exacerbations. And this is because we feel that recurrent exacerbations result in ongoing decline in lung function and ongoing decline in patients' quality of life and increases their risk of dying. The last two, preventing disease progression and reducing mortality, are sort of more aspirational because the current inhalers have not been shown to achieve these outcomes to any clinically significant way. And in fact, smoking cessation would have to be number 1 on our list in terms of reducing mortality and disease progression. And so in that regard, the inhalers offer us less at this time point. Now, just working through in the next 2 slides a sort of summary of these changes. So lung function now is no longer included in directing us in helping us decide on which inhalers to use. It still remains the gold standard in diagnosing COPD, and you'll see why that's important in a minute when I show you the next slide or 2. There's a greater emphasis on individualized treatment, and you'll see that we look at various characteristics of the patient with COPD, and I'm thinking here particularly of past history of asthma or allergy and atopy as being a feature that may help decide on which inhaler therapies we choose and in what order. There's also some guidance on escalation and de-escalation of treatment. In particular, I'm referring to when you introduce inhaled corticosteroids and when might you withdraw inhaled corticosteroids in your patient with COPD. And then the really exciting advent of or availability of the LAMA-LABA combination. So this is dual long-acting bronchodilators, 1 puff a day, 24 hours of coverage, and providing really some benefits that go beyond just the bronchodilating effects of putting these 2 different drug types together. Other things is the introduction of triple therapy, and to give you a sense of how important this is, the industry is now preparing inhalers that will provide all 3 drugs in one hit, 1 puff, 1 click. And I think that recognizes where we see the literature and the scientific evidence going. And this is obviously for the patients with a very high burden of disease and frequent exacerbations. The use of inhaled corticosteroids with the LABA combination is being modified on the back of having these LABA-LAMAs available, such that we're thinking now more towards patients with COPD who have a more asthma component. And this is a big problem in the respiratory community because this group of patients who have asthma that's gone on to become COPD or have been asthmatics that have smoked and now have irreversible airways disease, however you like to look at it, this is a group of patients that have been excluded from traditional trials, and therefore being able to draw on trial data in order to derive evidence to support inhaler use is a challenge. Nonetheless, the advice here being that patients with COPD who have asthma as a precursor disease or have had in childhood or for several years before they were diagnosed with their COPD, the high blood eosinophil count, in particular 2 areas where one might consider using the LABA-ICS combination as a priority. Continues to be concern about inhaler technique, and I think this is relevant in terms of these new delivery devices. You've got the dry powder devices of various sorts and the MDIs, and of course with those the spacers. So inhaler technique requires an ongoing assessment in terms of getting the best out of treatments. And then the other things included here, exercise programs and the emphasis about the benefits of exercise, even in mild or severe forms of COPD. The treatment of comorbid disease, and I'll talk a little bit about coronary artery disease, which I think I can safely say is undertreated in patients with COPD for a variety of reasons. And there are some self-management plans, but I won't go into those today. So let's just go on then and talk a little bit about FEV1. And as part of this, I'm going to share with you some unpublished data from a study that we've been involved in from a collaboration between our group here in Auckland and the USA, and a group of high-risk smokers followed for 6.5 years, and their outcomes, in this case dying, has been closely followed. And one of the interesting bits of information that has come out of this study is that in this group of 10,000, spirometry was done at baseline, and these were a group of patients about 55 to 74 years of age, 30-plus PAC years, current or former smokers, so a high-risk group. And when we looked at the data dividing this group up by their symptomatology, what they'd been told they'd been diagnosed with, what their spirometry told us they had, you can see an orangey red oval which reflects those that said, yes, I have COPD or chronic bronchitis or emphysema. And then you've got the group in the blue oval where they had spirometric evidence of having airflow limitation. And what you see in that orangey oval is about a half the group actually had spirometric evidence of COPD, and the other half that said they had it had actually okay lung function. So what is it about this group? They're very symptomatic. They have a lot of chronic bronchitis, but they have maintained normal lung function. They benefit from treatment, but they represent a slightly different subgroup. And the respiratory community recognize this and are busy thinking about ways to acknowledge and advise on how best to treat them. The other feature of this slide is the large chunk of people who have undiagnosed COPD. And this is typically about 2/3 of the total group when you do this type of study. You bring people in unselected, do spirometry, and ask the question, have you been diagnosed with COPD or adult asthma, airways disease if you like. And you can see that only about 1/3 of the group who have spirometric evidence of airflow limitation actually have been told they have airflow limitation, or at least COPD. And this is an issue in terms of making the correct diagnosis. Now, the GOLD 2017 criteria are still strongly supportive of spirometry and doing spirometry whenever you can. And it's something we don't do enough of in the tertiary centres, in the sort of hospital setting that I work in. We miss a lot of COPD. We know that this happens also in primary care. We know that there are lots of patients who present to their doctor with coughs and colds and sputum and breathlessness who may or may not get access to spirometry. The recommendation is to use spirometry in these people, so symptomatic people who have respiratory symptoms over 40, 45, and particularly with a past history of smoking. After you've established they have airflow limitation based on the FEV1 FVC ratio, you can assign a severity by way of a grade, if you like, and that's based on the FEV1% predicted. And this certainly predicts a number of things, and I'll show you some data. It predicts your likelihood of dying, it predicts your likelihood of getting lung cancer, and it also predicts your likelihood of dying of cardiovascular disease. And quite while those two things go together, apart from smoking, opens an interesting question. Next slide. Here we go. So why has FEV1 really been abandoned as a tool to decide on treatment therapy? And the reason, and many of you will be familiar with this slide, is that it correlates poorly with clinical outcomes relevant to the patient. So in this slide, there are 4 quadrants. Each of those graphs have the lung function on the bottom, on the x-axis. The vertical axis is describing, in the first one, their breathlessness score on MRC. And the top right is the St. George's Respiratory Questionnaire, which is a composite questionnaire of quality of life. And these, while there is a so-called row value, these are not are very clearly correlated. There's not a straight line to be had there. Down the bottom, you have the 6-minute walk test, and then on the bottom right is the exacerbation history. So because FEV1 correlates poorly, then there is issues about its utility in deciding how you scale up your treatment options. The old days, we had 3 parameters in the quadrant system. That involved spirometry shown on the left, the symptom score on the bottom, and the exacerbations over on the right. And this has been simplified now to just involve the symptom scores on the bottom and the exacerbation history on the right. So really 2 parameters in a 2-dimensional figure, and I think that makes good sense. And from this, then, the capacity to identify a patient with COPD, understand the severity of their breathlessness, and then understand their frequency of exacerbation, and then from that, make a decision about the inhaler regimen you think is best for them. The CAT score, hands up who's using CAT. Okay, that's pretty good. I mean, the numbers steadily grow. It's been well validated. It's a clinical score that replaces the research tool called St. George's Respiratory Questionnaire, based on 8 factors scored by the patient, done in the waiting room, and providing the doctor or healthcare nurse worker or otherwise with a sense of the symptoms and which ones in particular this particular patient finds troubling. There's a cutoff of 10 and below being mild and above 10 being moderate, going up to severe and very severe. In exacerbations, it wouldn't be unusual for people to be around 20, 25. And then as they get better, the score might drop down to the mid-teens. That may take 2 weeks after an exacerbation, certainly for hospitalized patients. So to give you a sense for how this score can change with exacerbations, this score has also been recommended to assess new treatment and the effects of new treatment to see if you can indeed improve cough, reduce phlegm, breathlessness, and so on by using a scoring system like this to test how well that treatment worked. I think it has that utility. An alternative is the so-called modified MRC or respiratory breathlessness score. Medical Research Council put this forward many decades ago. 2 is the cutoff point at which we would describe as being high for symptoms. And at this level, on level ground, I walk slower than people of the same age because of breathlessness, or I stop for breath walking at my own pace. So this refers only to really exercise tolerance as opposed to the more complex CAT score. So then, moving on in terms of the new recommendations, I have mixed feelings about this figure. I'm not sure if we've made things easier or harder. I think possibly the latter. But what it does do is it provides us a little bit of insight into where the respiratory COPD gurus of the world are thinking. So they've stuck to an ABC quadrant system with patients at mild and early disease, if you like, in quadrant A. And here the patient typically would have a short-acting inhaler, and they may also have moved on to a long-acting monotherapy inhaler. And what's interesting in this one is the use of, in the box above, LAMA, or long-acting muscarinic antagonist, as a first-line choice for long-acting bronchodilatation. And in fact, in a recent review article, there was very good evidence to support this over a LABA monotherapy in terms primarily of the ability to reduce exacerbations. So there may be a bit of debate around that, but to say that the A, B, C, D, really patients may transition from A to B, they may transition from A to C, and then they may transition to D, but not all patients go through any one or all of these quadrants. Okay, so one just needs to bear that in mind. And I guess because of that, they decided they needed to complicate things by putting in a whole bunch of choices in each box. Personally, I prefer just a single choice per box, but and I'll show you something that does that. The other thing, well, let me just go through this and just describe here something that we have proposed, which may or may not make things easier. But in here, you can see in our box A, we have the the single short-acting going to the LAMA in box A, Raywin, box A. And thank you. And so that, thank you, that's perfect. So there you see the introduction of a long-acting muscarinic antagonist, first-line monotherapy. And then if you go across to box B, you increase to the LAMA-LABA combination for persisting symptoms. If someone is exacerbating, you might be going up to box C, and there you've got a choice of LAMA-LABA or LABA-ICS. And this is the discussion I'll describe a little bit about why you might choose one from the other. And then the most severe patient with the triple therapy. And I think that people are generally happy about that, and I'll show you a little bit of trial data suggesting that this makes good clinical evidence or good sense. So starting then in A, as I said, is generally short-acting treatment or monotherapy of the LAMA type, and this is really based on patients who have been diagnosed primarily based on symptoms and who do not have exacerbations at this time point. And apart from the treatments at the top, which are the short-acting treatments, down the bottom there in the red box is the long-acting mono therapies, the LAMA therapies here that we have at our disposal now. A couple of the new ones there, the umeclidinium from GSK, and we've also got the Seabri, and we also have the tiotropium products as well. And then we go on to really the LAMA-LABA, and this is really where things have changed, and really of the last year or so based on massive clinical trials showing that the LAMA-LABA combination not only improves symptoms and improves lung function, but reduces exacerbations. And I think this was of interest to the respiratory community in terms of mechanistic basis to this, but certainly as a clinical tool and as an addition to existing LABA-ICS was a great addition to the treatment options. And then up in C, you can see the transition from monotherapy to dual therapy. And here you can see that you've got a choice. And as I say, I'll describe a little bit about how you might make that decision in a minute. So what were the studies then? The AFFIRM and FLAME trials looked at LABA-LAMA versus the LABA-ICS and found them to be superior on the whole in terms of these important clinical outcomes. Another study called the WISDOM study looked at withdrawal of LABA-ICS and substitution with the LABA-LAMA and showed that there wasn't a major deterioration in frequency of exacerbations, giving us a bit more confidence that LABA-LAMAs could fill that role. And then the SUMMIT trial looked at a completely different outcome, and this was to look at the combination of a long-acting beta agonist and ICS in patients at high risk of heart disease. So the respiratory community is starting to think about other reasons that patients with COPD have poor outcomes, and it really is because of, and to a large degree, high rates of lung cancer and high rates of coronary artery disease. And really in this study there was not benefit, and I would go back to things like getting patients to quit smoking and reducing exacerbations as a means of reducing cardiovascular risk alongside our traditional tools of aspirin and statins. This is a little bit of data just looking at what happens to your lung function on these individual therapies, and you can see here you get a really good benefit with the LAMA monotherapy, small increment benefit when LABA is added, and then overall the dual therapy being superior, and that in fact this increase in lung function is maintained over weeks and months of therapy, up to 4 months or more. You can see these two lines don't converge, they stay separated, so it's not any sort of tolerance or getting used to the medication. The prolonged bronchodilatation achieved with dual therapy is maintained. Now a little bit about ICS-LABA and its modified or new role, if you like, in the COPD world, and that fits into box C, as I say. This is the group of patients that are having exacerbations. That is both the C and the D box for frequent exacerbators. So here then, what is your choice and how do you make it? Well, the recommendation is for the ICS-LABA as a first choice in patients with coexisting asthma or a history and or findings suggestive of an asthma-COPD overlap. And I think things that are helpful here is where there's quite a significant reversibility, where there's been a prior history of asthma, particularly asthma in childhood, and features of allergic disease, atopy, eczema, and allergic rhinitis. And secondarily, but probably somewhat more contentious, is the idea of looking at serum eosinophils. Has anybody here been exposed to the serum eosinophil treatment approach to COPD? A few people, yeah. It's just making its way into our consciousness. I think it's probably hasn't been broadly adopted in part because not all the specialists, and I'm talking about the experts that come from Europe and America that tell us what we should be doing, agree on this. So it's a space that is still filled with a bit of discussion and debate. But there's certainly growing interest in the idea that if someone has persistently elevated serum eosinophil counts, then they are more likely to be responsive to inhaled corticosteroids, and therefore may benefit from preventive therapies involving inhaled corticosteroids. Now, this is really new data that's come out in the last year or two. Again, the focus now being, so what is this ACOS group, the asthma COPD overlap syndrome, that have been traditionally excluded from trials, clinical trials. And you can see here, history of asthma in childhood, 20 years of asthma preceding the diagnosis of COPD with a background of smoking, atopy, allergic rhinitis, the things I mentioned before, and this high variability. These are thought to be clinical features, but it's still debated. How frequent is this problem? It's about 5% or thereabouts of the larger groups of COPD patients, but again, it depends a little bit on who you study. And then the idea being that this group may be more steroid responsive. This is just one of many graphs that have been provided to support the idea that serum eosinophils may be useful. It's a post hoc analysis of just one study, the brown bars being those on dual therapy and their exacerbation rates being relatively constant across the different levels of eosinophil, but the light blue bars are people who are just on LABA, no ICS, with an increase in exacerbations as the eosinophil count goes up. So just watch this space because more data is being collected in this area. So triple therapy then, in this most severe group who are troubled by lots of symptoms, lots of exacerbations. A couple of trials have been published for Phil, Trinity, and Trilogy. They're wonderful names. They look at the combinations, and these are really got great opportunity here because they're single puff, once a day type treatments. So in theory, at least, compliance should be very good in this group of patients using this type of medication. And so far, the triple therapy approach is superior to a LABA ICS dual therapy. I think there's still literature emerging comparing the triple therapy with the LABA-LAMA combination. But nonetheless, watch this space. So a little bit about withdrawing inhaled corticosteroids. Again, a discussion and debate ensues around this area. I think the recommendation would be for patients whom you think have ACOS, and in our schema here, you can see the E category here going up on the left-hand side. These patients often start out on inhaled corticosteroids and then added into LABA as part of their asthma treatment, then become irreversible or minimally reversible. They may have smoked and become, if you like, COPD. That's a group who you would not withdraw inhaled corticosteroids for, I think. But others who are clinically very stable, you may have concerns regarding pneumonia or other inhaled corticosteroid-related side effects such as cataracts, and you may consider withdrawing ICS from that group of patients. Low blood eosinophils may give you a little bit more confidence in doing that. Anecdotally, a lot of my colleagues have done this, and patients have unfortunately deteriorated, and they've ended up putting them back on their ICS, but nonetheless, I think it's worth thinking about. So just one slide on non-pharmacological treatments to say vaccinations are still recommended. A lot more emphasis on exercise and regular exercise, walk till you're puffed, and really maintain good conditioning. And it's believed to have an anti-inflammatory benefit of its own. Pulmonary rehab is maintained as an important feature as part of that, and also just physical conditioning, confidence, and inhaler use optimization. Diet can be optimized, again, along the idea that COPD is one of a series of manifestations of systemic inflammation, and that diet high in fruit, veggies, and fibre can help reduce that systemic inflammation, and with that your respiratory inflammation. And a little bit about coronary artery disease, seen at the bottom here. And as I say, some evidence in a audit that we did in patients in Auckland admitted with COPD being really undertreated for their coronary artery disease. This is a little bit of data out of one of our studies showing what happens to your risk of dying of lung cancer in black and your risk of dying of cardiovascular disease according to your baseline lung function. And you can see as you move from gold 1 to gold 2, the red bar of cardiovascular death comes up to meet that of lung cancer and stays with it going into gold 3, 4, where respiratory deaths in blue becomes more of an issue. So there's this, and just to say that we believe that once you control for smoking and age and gender, this is quite a powerful effect and indicates that COPD is a marker of cardiovascular death, and others have shown this epidemiologically. More interesting for us was in an analysis of this data set where we compared these two groups here. On the left, you see those that are COPD with not diabetic, compared to people on the other side of that box who have normal lung function but are diabetic. And you will see the two red bars are almost equivalent. So if you think diabetes is a risk marker for cardiovascular disease, so is COPD, and about to the same level. So just to tidy up then and finish off, Group A, we've got monotherapy, short-acting, plus or minus LAMA. Group B, we're talking really about patients who benefit from LABA-LAMA. Then in Group C, we're talking about LABA-LAMA combination or LABA-ICS combinations. And the most severe group, triple therapy. We were able to be involved in a publication that came out in Respiratory Review, and we have some copies of that here, which we can leave on the front table for anybody who has not seen this article, which provides an overview of what I've just said. So thank you very much.